be only in talking and discussing. Thank you.
Thank you. Point noted. We have many hands online, but I'm just going to give a chance to two people. Giving a chance to Ariki. Ariki, you can unmute. And then
Unmute me.
Okay. Thank you very much for the presentation. I have two-part question. One, is resistance to anti-malarials a concern, and is this patient a suspect to have probably a history of resistance to anti-malarials? That's one. Two, how do you make a clinical judgment in ruling out other important differentials? Is it based on how your patient is responding to the initial treatment plan, or do you actually go ahead and investigate in a patient in a coma like this? Because it could be meningitis, the patient has GCS of 8, and they have come to the hospital, and it looks like people have only focused on treating malaria. How do you make a judgment that I'm not going to start this patient on broad spectrum antibiotic, especially if you are in a rural community where you cannot, do a blood culture, or you cannot, do any radiology to rule out any brain lesion? Why would you not start antibiotic at that point? I just want clarity on those. Thank you.
Thank you so much, Ariki. But I think the presenter. From our case presentation, Dr. Ronald really told us that they wanted to go ahead to do a lumbar puncture because I think it was within their capacity, but however, they had challenges and they didn't do it. However, also the canines, when we did the canines, was negative. So they ruled out meningitis. But I think if you are in a center where you can do a CT scan, you can go ahead to do a CT scan if you're thinking that maybe the patient could have another complication, maybe it's having intracranial bleeding or been, for example, having in your history, in your medical issue, you found that the patient maybe is hypertensive and maybe is having elevated BP and you're suspecting maybe you could have gotten a CBA. So you're going to use all your clinical acumen and you're going to use the investigations that you're able to. But maybe what Dr. Wamala emphasized that you shouldn't be routinely to give antibiotics. You should have a rationale to everything that you do to the patient. Yeah, some people are asking us to throw more light about Primaquine. Some insight, please, on the use of Primaquine. And then what's the difference between recrudescence and co-infection in malaria? Another question is it advised to manage sick suffering from malaria with quinine as a second line when Addisonate fails? Someone needs some light on that. I think we are going to have only those. For other people, guys, type your question in the chat. We have someone online who is going to be attending to that.
Thank you, our online attendees. First was we are recommending duocotexin, yet the health center 3s are getting Coartem. So Coartem can also be used as a continuation after the initial Artesunate. So it can still work. So if you have Coartem, use that. It is better than not giving the patient anything. Risk of resistance to antimalarials, yes, even there are reports of resistance to Artesunate. in some countries. Here in Uganda, not so common, but yes, there can be resistance to those antimalarials. Rolling out other differentials, it all begins from history. You need to take a good history. You need to do a good physical examination. So history and history physical examination gives you, we are told it gives you almost 80% of the diagnosis. The challenge is that our clinicians want to take shortcuts, but take a history, examine this patient. It could be meningitis, could be cerebral malaria, it could be stroke, which has made this patient lose consciousness and convulse. So your clinical acumen will be able to guide you. But like I said, if in your assessment you believe that this patient highly has another focus of infection, please treat. Cover them with the antibiotics. And the other trick which I normally use when I'm making a diagnosis, I always ask myself, what if I am wrong? What if it is not severe malaria? So it enables me to think through again and see how is my thinking process? Is it right? Is it? So it keeps you in line. So always ask yourself, what if I'm wrong? It guides you on how to go about it. Okay. Primaquine, we know primaquine is used for chemical prophylaxis. So the recommendation is if someone is coming into a malaria endemic area, they begin with primaquine 2 weeks before travel. That is 250 milligrams weekly for at least 2 weeks before they travel. Then when they are in the area, they continue with primaquine weekly. When they leave and go back to their country, they continue with primaquine. No, sorry. Was it primaquine or mefloquine? The question, was it primaquine or mefloquine?
It was primaquine.
Primaquine, oh. So primaquine is used to prevent recurrent, to clear the residual parasites in the liver, especially for Vivox malariae, because the ACTs don't clear those parasites. So yes, you can treat the patient with severe malaria. They go back home with residual parasites in the liver, and then a few weeks down the road, they come back. So in your continuation treatment, you need to cover for that. So that means that the lab should be able to type the parasite for you. If it is Parasparam, no need for primaquine. If they type Vivox or malaria, then it means you need, on top of the duocortexin or the coatem, you need to add primaquine to clear the residual parasites in the liver. Is it advisable to give cycloquinine? First line, artesunate. If it's not there or they fail to respond, antimethac. If it fails, then you have no option but to bring out your what? Your quinine to treat this patient. I think those were the issues.
Dr. Omar, before you put down the microphone, can you please talk about mefloquine as you talked about it?
So mefloquine is for chemo prevention. Person who is naive to malaria is traveling into a malaria endemic area. They are highly at risk of getting severe malaria. Even just a 1+ can throw that patient, can make that patient to have cerebral malaria. Yet for us, 1+ may not throw you down like that. So they need to take chemoprophylaxis. So it's recommended 250 milligrams at least 2 weeks before they travel, which is taken weekly. Then when they reach into their destination where they are going, they continue with it weekly. When they leave and go back to their home country, they continue taking it weekly for at least 4 weeks. So that is the recommendation.
Thank you so much, Dr. Wamala. This time I'm not going to take any more questions. Please type the questions in the chat. I'm going to welcome Dr. Doreen to continue with the management of common complications. As Dr. Wamala has given us a lot of them while he was giving us his presentation, and from our case presentation, we really saw a number of complications of malaria which these patients have. So Dr. Doreen is going to take us through management, like specific management for some of the complications. Okay. So welcome, Dr. Doreen. Thank you, moderator. For us to understand how these complications are managed, we have to understand what the malaria parasite does to the body. So when a female Anopheles mosquito, an infected female Anopheles mosquito, bites someone, it injects the parasites into the body. These parasites then move into the liver, and then from the liver, they then move to the red blood cells. And then the cycle continues. So that means that these parasites at a certain stage enjoy the presence of the red blood cells, and that's going to explain a number of the complications that we're going to go through. I'll start off with the cerebral malaria. Cerebral malaria is very common, especially in children compared to adults. But the clinical manifestation is altered mental status, of which coma is at the end of that spectrum. Altered mental status could be disorientation, it could be altered speech, it could be abnormal movements, and the final end leads to coma. So what happens is that these infected red blood cells adhere to the blood vessels within the brain. When they adhere to the blood vessels within the brain, there's a process called sequestration, where they block these blood vessels. And when they block these blood vessels, therefore blood is not flowing adequately as it should. So perfusion is affected. We know that blood carries oxygen, blood carries glucose. So the cells in the brain are depleted of enough oxygen, they're depleted of glucose. What happens? Hypoxia, necrosis, cell death. And that goes on to explain your altered mental status, your seizures, it goes on to explain the unequal pupils, etc., etc. So the seizures in cerebral malaria are not special in any way, the same way that you're going to manage seizures for any other abnormal cause. To make a diagnosis of cerebral malaria, you need to rule out hypoglycemia, and you need to rule out any other cause of altered mental status. So you need to rule out toxicity, you need to rule out meningitis, you need to rule out trauma, you need to rule out any other features that could cause altered mental status in your patient. So how we manage cerebral malaria, apart from the definitive management, one, you need to ensure that if a patient is having a convulsion, put your patient in a recovery position, make sure that you give them our setting, we make sure that we give benzodiazepines, which is first-line management for convulsions. We give diazepam, 0.2 milligrams per kg, or you can just round it off to 10 milligrams IV for an adult. The ceiling dose in 24 hours is 30 milligrams, which means you can only give it a maximum of 3 times. If your patient is still convulsing, like I said, rule out any other differentials as to why your patient could be convulsing. Are they convulsing because of hypoglycemia? Are they convulsing because there's some sort of toxicity? Are they convulsing probably because they fell and now we have some sort of brain bleed? So you need to rule out all these other features. If your patient then enters a state of status epilepticus, then you move to your other anticonvulsant drugs. Phenytoin does not stop your seizures directly. Phenytoin prevents the occurrence of a further seizure. So that means that if your patient is convulsing, I do not expect that you're going to give phenytoin to stop the convulsion. It does not do that. What phenytoin does is it is just to prevent any further occurrence of a seizure. And how we give it in adults is you should always give a loading dose. The loading dose is 15 milligrams per kg, most times round off to 1 gram in an adult. It's important that you treat your patient. Do not treat the textbook, do not treat the guideline. Treat what is in front of you. Like Dr. Wamala has stated, if you have managed the cause of the convulsion, then you might have to question, do I really need to put this patient on a maintenance dose? However, if there is risk to another convulsion, the maintenance dose is 100 milligrams, 8 hourly in 24 hours, okay? Remember, this is a patient who's convulsing, so it's very important to manage the airway. It's very important that you assess your patient because most times we're worried about airway compromise in our patients that are convulsing. The other common complication in severe malaria is anemia. These parasites affect red blood cells of all stages. So whether they are young or old, depending on the stage of the red blood cells, the parasites will affect the red blood cells. And they love the red blood cells. We know that the red blood cells are responsible for oxygen delivery. But also what the parasite does is that it prevents formation of new red blood cells. So it affects the bone marrow. The type of anemia that we have in severe malaria is hemolytic anemia. What the parasite does is that it causes hemolysis, it causes the destruction of the red blood cells. It stays in the red blood cells for a certain period of time, and while it is there, it matures, and then it releases a new stage of the parasite. In that process, the red blood cell then disintegrates. So you have what you call a hemolytic anemia. Now, go back to your clinical skills, examine your patient, check for pallor, do your baseline HB, and make sure you assess if your patient is anemic. Management of anemia, you have to give whole blood. If you don't have whole blood, you can give packed cells. The other complication is acute kidney injury. The type of kidney injury in severe malaria predominantly is renal. So your patient might not necessarily be going into kidney injury because of volume, but because the parasite directly damages the kidney. Now, that means that this mentality that for every patient who has AKI, I should pump fluids should stop. Because you're going to put your patient more harm. Yes, you could have reduced volume due to GI losses, maybe your patient is vomiting, or your patient is not taking in as much, but the pathology is because the parasites are directly causing acute tubular necrosis. Your infected red blood cells affect the blood vessels within the kidney, causing damage. So also other things that can cause acute kidney injuries, because remember there is hemolysis taking place. These products of hemolysis also affect the kidney. So how do you manage? So AKI is one of those things that you need to anticipate in your patient. Do not wait for your patient to get to a point of acute kidney injury. As a clinician, there are certain things that you can anticipate. So that means monitor your urine output. Mm-hmm. For an adult, you want to aim for an output of 1 ml per kg per hour. If we go back to our KidGo classification of AKI, any patient that has a urine volume of less than 12 mils per kg in 24 hours, you should start questioning, is my patient having acute kidney injury? Also monitor the creatinine levels. According to Dr. Wamala's presentation, it was very clear, if you have creatinine above 3 milligrams per deciliter, you are now turning towards acute kidney injury. So like I said, your patient is not having acute kidney injury because of reduced volume. No, your patient is having acute kidney injury because the parasites are causing damage to the kidney. So go slow on the fluids. I'm not saying don't give fluids, but give fluids. Give fluids precautiously. You have to calculate the maintenance dose of your patient. For an adult, you can use the 4-to-1 rule, identify how many kilograms this patient is, how many meals do they need per hour, make an assessment, make a clinical judgment, are they feeding orally or not, try and calculate their losses, etc., etc. Our nurses are very good at doing this. Get your fluid balance chart and balance the fluids. How much is my patient taking in? How much are they losing? And then from there, you can now titrate it according to the urine output. You have a target and say, I want to aim probably for 70 mils of urine per hour. So then start titrating your fluids according to that. If you give too much fluids, you're going to push your patient into fluid overload, which is also dangerous, okay? The other complication, which is not so common, that we also overlook is the acidosis. Acidosis is metabolic. Now the body works in such a way that it has to maintain balance between the positive and the negative ions. So what happens is that because of the parasites, our parasites, the malaria parasites need to feed, they also utilize glucose. Lactate is produced as a byproduct of glucose production. It happens in a simple way when you do exercise and get a muscle cramp. The muscle cramp is because of lactate being produced. So lactate is produced by all cells, but most especially the muscles, but also the red blood cells. So what happens is that the parasites utilize glucose and hence produce lactate. But also because of the immune response of the cells to the parasites in the body goes into hyperdrive and then utilizes more glucose than it should. So then you have also increased lactate. The other thing is that because of hypoxia happens because of anemia, but because of that sequestration process that happens in the cells, the body goes into a state of anaerobic processes to break down that glucose, hence lactate. Now remember what is happening in the kidneys as well. You have acute tubular necrosis, you have kidney damage, but also remember that there is also liver damage. And we know that the liver cells also support the process of production of glucose for the body. So what happens is that you have an increased amount of lactate and you have decreased secretion of lactate. So you have an increased amount of lactate in the body. Lactate goes up, acidosis goes up. How do you identify lactate metabolic acidosis in your patient? Go back to your clinical skills. These patients will start to compensate. How do they compensate? They start to hyperventilate. They breathe very fast and they breathe very deeply because they want to expel carbon dioxide. They want to expel as much of this carbon dioxide so that they can balance the body back to how it should be. The other signs are the vomiting that can happen, but also because of the lactate, it could explain the muscle cramps that your patient gets. They also explain the joint pain that your patient could get. So, like I said, as a clinician, you want to anticipate some of these complications before they actually happen. What do you do? Ensure your patient is resting. Make sure they're not utilizing as much energy. You want to ensure that they're not consuming as much glucose as they should. So when you fall sick of malaria, rest. Rest. But also for our patients, you want to encourage hydration. You want to give fluids orally. or like I said, be cautious with your IV fluids. The other thing is that you give oxygen, support the body, ensure also that your patient is given enough glucose as they should for their maintenance. If you're in a center where you can do ABGs, good for you. You can do your ABGs, and this can also guide you. The definitive management for your acidosis is sodium bicarbonate, but consult. Referral is part of management. Consultation is part of management. Never be worried or scared to ask. Always ask for help. Where you don't know, ask. Always consult. I'm sure Dr. Wamala and Racheal will tell you that learning never stops. So where you're not sure, ask because you could cause more complications to your patient. Very commonly, we have hypoglycemia. Hypoglycemia basically means that there is low blood sugar available for the body's cells. How this happens is that the parasites also utilize glucose. They also have to feed, they also have to function. But also what the parasites do is that they alter the process of formation of glucose within the liver. Like I said, the liver cells can be damaged, and therefore there is not enough glucose readily available for your patient. The other thing is that the patient could be not feeding, could be due to starvation, and therefore it pushes them into hypoglycemia. Features of hypoglycemia, again, go back to your clinical skills. Patient is disoriented, they are confused. You know the feeling you get when you take long to eat food, you start sweating, you get irritated, you get disoriented, you get confused. So do a baseline blood sugar test, a random blood sugar, very important. Assess your patient's blood sugar. Hypoglycemia is any blood sugar less than 4 millimoles. Give dextrose, not 5%, 50% dextrose. If you're pushed to the wall, you can go to 25% dextrose. And I'm talking about adults. The dose for dextrose in adults is 1 ml per kg. So that means if I'm 70 kilograms, gives me 70 mils or 50% dextrose. If you don't have 50% dextrose, give D25. The dose is 2 mils per kg. Okay? So we're into the habit of 1 dose for everyone. Whoever is hypoglycemic, I'll give 30 mils or I'll give 20 mils. No, because the amount of 50% dextrose you give me is different from my colleague, is different from my neighbor, because we all weigh differently. The other thing about 50% dextrose is that give it slowly, it's given IV, and do not dilute it, okay? So it's either D25 or D50 in your adults. I'm going to hand over to my colleague, Dr. Wamala. I think I've talked a lot to go through the other complications of severe malaria. Okay, yeah. So basically, it's very important that when you have a patient who comes in with malaria, you want to think ahead. You want to anticipate and try and prevent these complications from taking place. Like I said, you can prevent the hypoglycemia by ensuring the patient is feeding. You can prevent the acidosis by making sure your patient is resting, making sure your patient is getting enough fluid. You can prevent the AKI by maintaining the fluid, etc., etc. Very important that you get these complications and always prepare just in the event. Now, one thing, how do you make a decision that this patient needs to be referred, or how do you make a decision that your patient is needs support, especially advanced support, probably in the ICU or in the HDU? You need to rely on your clinical judgment as a clinician. You are with the patient, you are seeing the patient in front of you. If you're in a center where you cannot manage the complication, or the patient is not improving, please refer this patient. If you're in a center, for example, where your patient is not responding to benzodiazepines or is not responding to first-line therapy, refer this patient. If this patient is in need of dialysis, like I mentioned, please refer this patient. If you're in a center where the patient needs advanced care or needs to be intubated, needs mechanical ventilation, please refer this patient. Thank you so much, Dr. Doreen. Wow. If I have missed anything from your presentation about prevention, as always, we say that curative medicine. As we already say that curative medicine is expensive, as we know that we are in a low resource limited setting. Just imagine you get complications of malaria that are not picked up, patient is going to stay long in the hospital, the family is going to be affected. So if I've missed all other things, I've picked prevention, anticipate these complications and try to prevent them. Dr. Doreen, I have a question for you. So you talked about acidosis and the way how we can tell that maybe this patient has acidosis. And I mean, this center where I'm unable to do ABG, and my patient is having all those things that you talked about, is having deep respiration, is confused. Now I'm thinking he has acidosis. Should we go ahead to give sodium bicarb? So, like I said, there is always a stepwise approach to your patient. So before, definitively, yes, sodium bicarbonate is very important because it will help your patient who's having metabolic acidosis. But it's one of those drugs where you cannot give it without consultation, you cannot give it without getting support from your anesthesiologist or your critical care specialist. If you don't have access to sodium bicarbonate, like I said, there are simple things that you can do to help your patient. One, give oxygen. Remember, your patient is air hungry. They are hyperventilating. Give oxygen to support them. Two, you can actually give them fluids. Like I said, you want to, and this is a point I want to make very clear. IV fluids think of them as a drug. So for every drug, there should be an indication, and then there's also a justification, but there's also overdose. So calculate your maintenance fluids, titrate, and give fluids to support this patient. The other thing you can do is you can ensure this patient could be having lactic acidosis because of hypoglycemia, okay? So the body is not getting enough glucose, and therefore the body goes into a state of hyperdrive. It's trying to produce more glucose. So monitor your glucose levels and support your patient. All these are simple things that you can do en route to a critical care center where you're going to find a specialist who will support you. So before you rush to pull out your sodium bicarbonate, do simple things. If we can master the simple things and then we do them excellently, I think we can save our patients. Thank you so much, Dr. Doreen. Dr. Wamala, there is a question here in the chat. Someone asking, when do you consider changing to the next line of treatment?
Thank you very much. So, what you cannot measure, you cannot improve. So, meaning that you should be, maybe before I go into that, Dr. Doreen talked about when to consult. You need to have a monitoring plan for the patient. You need to monitor the temperatures. How are they going? The GCS, the BPs, the urine output. So if you have a monitoring plan, it will be very easy for you to determine that things are not going well. I need to refer this patient. So the question was, when do you determine that?
When do you consider changing to the next line of treatment? And that question is twined with another one saying that can a person with lab result of MPs 1+1 be classified as severe malaria? So there are two questions in one.
Maybe let me begin with the second one. The definition of severe malaria is presence of sexual forms of malaria parasite in the blood with any one of those complications we have been talking about. So if a patient has just one plus, but has severe hypoglycemia, has severe anemia, is comatose without any other possible explanation, that is already what? Severe malaria. Don't wait to have 4+ for you to think about severe. If a patient has any one of those complications with presence of malaria parasites without anything else which can explain that, that is already severe malaria, and treat it like that. When you decide to change, the guidelines don't go so much deeply into this, when you should change, at what point, but it is case-by-case basis. You the clinician who is seeing these patients, you've given 3-4 doses of artesunate and the parasites are still as they were, the patient is still spiking fevers, then most likely the artesunate is not what? Is not working. So you've given 4 doses of antimether, parasites are still many, patient is spiking fevers, is vomiting here and there. Most likely the medicine is not what? So there is no clear-cut duration. It is on the discretion of the attending what? Clinician. Yeah.
Thank you so much, Dr. Wamala. We have very many questions in the question and in the chat, but at this time, we've seen the management, and Dr. Wamala has talked about monitoring. So at this time, we want to have what is the nursing care in these patients that are having malaria? How should we manage them? What should we do and what we shouldn't do? So we are going to have Sister Lucy taking us through that presentation now.
Thanks very much, Madam Moderator. I'm presenting about the nursing care management for severe malaria in adults. So the first and foremost, we have patients' vital observation, monitoring patients' vital observations frequently by taking their blood pressure, pulse rate, temperature, respiration, and SpO2. Then the second one, hyperexia in patients with high fever, epic sponging is required. Or you can also give antibiotics, e.g. tabs paracetamol, 1 gram, every 8 hours to reduce the fever, according to the clinician's prescriptions. You can also open windows for fresh air. You can expose to reduce the core body temperature by removal of additional layers of coverings. Then we have convulsions. In this case, where this patient presents with convulsion, you give anticonvulsants, e.g. diazepam 0.2 milligram per kg or maximum of 10 milligrams slow IV in adults, or 0.5 milligram per kg rectally. You also position the patient in a recovery position. You have treatment, giving the antimalarial treatment following the doctor's prescription. For example, first dose of IV artesunate at 0 hours, second dose at 12 hours, and the third one at 24 hours. Most importantly for a nurse, you have to give the right drug to the right patient, right word, and right dosing. In adults, all children greater than 20 kilograms, you give 2.4 milligram per kg. Child less than 20 kg, give 3 milligram per kg, then once a day, until patient is able to tolerate oral medication. In dehydration, you have to correct dehydration by encouraging patients on a lot of oral fluids intake or using ORS. And in this patient who is unconscious, you pass NG tube for feeding. You can also rehydrate this patient using IV fluids, preferably crystalloids, 20 milligram per kg bolus, or as prescribed by the clinician. And remember to monitor the fluid balance, reassess patient, and check again for the dehydration. And remember to report in the fluid balance chart. For this case, you insert urinary catheter to monitor fluid input and output. Then you also chart in the fluid balance chart. In severe anemia, blood transfusion is required. As a nurse, you take sample for grouping and cross-match to transfuse patient with packed cells or either whole blood following doctor's prescription. Monitor patient on blood transfusion for any signs of blood transfusion reaction. You also keep on monitoring the vital observations. Under feeding, you ensure patient is feeding well. In this case of our patient who is already unconscious, we pass NG tube for feeding. We also monitor blood sugar level. Then there is hypoglycemia. If RBF is less than 2.2 millimoles, that one you consider it is already severe hypoglycemia. If less than 4 millimoles, hypoglycemia. Then here you treat using IV dextrose, 25% 2 mg per kg by slow IV bolus over 3 to 5 minutes. Or you give 50% dextrose, 1 mg per kg, as also IV bolus. Then shock. In this case, where our patient is already in shock, you raise the foot of the bed to increase the blood supply reaching the brain. Give IV fluids. For example, give either IV normal saline or Ringer's lactate as fast infusion, 20 mg per kg, 15 minutes. Then you reassess again patient. Also review here fluid balance, urinary input and output, and you remember to chart in the fluid balance chart. Then health education. You give your health education to the patients and attendant on the general body hygiene. But for this case of our patient where the patient is already unconscious, you do it yourself. You do oral hygiene, bed bath, 2-hourly turning of patient to prevent bed sores, or you nurse in the air mattress bed. Then when your patient is recovering, you give early ambulation, give education to the patients and attendant on the prevention of malaria, like sleeping under treated mosquito nets, clearing of bushes around their homes, removal of broken pots around their surroundings, clearing of stagnant waters around their surroundings. And also remember to do the general nursing care of unconscious patient. In this case, patient required also suctioning of oral secretion, PRM. Then you nurse the patient in a recovery position or position of comfort. You also have to place OPA, in this case, to clear the airway, or NPA. Then lastly, as a nurse, you remember you are the one at the bedside all the time. So you watch out for life-threatening changes in this patient and you report any to the clinician. Thank you for listening.
Thank you so much, Sister Lucy. You talked about the vitals, and Dr. Wamala emphasized, because if you're not monitoring your patient, you won't know when to refer, when to consult, and what to do. So this time we are going to have a video session of how are you going to put this patient in recovery position. Remember, for this case presentation, our patient was unconscious. And to prevent airway from being compromised, it's very, very pertinent for us to put the patient in recovery position. However, it's a skill that everybody should know how to place a patient in recovery position. So we are going to have a video session, and Dr. Doreen is going to take us through how you put a patient in recovery position. If you had a physical audience, we would have hands-on and practice. But thank God for the internet, we can still demonstrate what we want to learn and pick the skill. So at this time, I think, I don't know whether the video team is ready. Okay, maybe as the video team is still setting up, Dr. Wamala, I know we are going to have a question and answer session, but there is a patent. Oh, yeah. Okay, we can pass out the video and then we go through the question and answer session. People are having very many questions.
Audio, please. No audio. Not audible, please.
I can't hear either. I can't hear. Is it my network or?
Sorry for that, for not hearing, but if you've been following very well, we want you to observe what the person in the video was doing, and Dr. Doreen is going to take us through the steps, what we watched on the video. Okay, so the recovery position is a position that you put a patient in after they have had a convulsion. After they have had a convulsion, not during the convulsion. When you have a patient who's actively seizing, what you can do for them is clear anything that could harm them. So if there are any sharp objects around, if there's anything that you see that could fall on them, clear it away from the scene. Also, if your patient has an IV line, you want to give your medication. Definitive management, first line is your benzodiazepines. We've talked about this. So your IV diazepam, 10 milligrams start. And then once that convulsion has stopped, then you put your patient into the recovery position. So what you want to do is get the patient onto the bed, or get the patient from the ground, wherever the bed convulsing from. You want to make sure that the patient legs are straightened out in front of them. Then you want to lie down next to the patient. Preferably, you're going to, depending on what side you want to turn them to. So if you're lying down on your patient's left-hand side, you want to stretch out your patient's left arm, and then we do what you call a high five of your patient. So you get your patient's right hand and then place it on the patient's left cheek, okay? And then you want to lift up the patient's right knee, okay? So you move the patient's right hand and then you move the patient's right knee, as the video was stating. And then what you want to do is you want to roll this patient towards you, but as you're rolling this patient, you want to ensure that you maintain the airway as open as possible. Because of the position of the hand of this patient on the patient's cheek, you slightly elevate the patient's neck to ensure that in case this patient was vomiting, in case this patient has any secretions, these secretions, or if this patient continues to vomit, then their airway is protected. Unfortunately, we cannot demonstrate it here, and unfortunately, you cannot hear the video, but I'm sure that if you Google how to place a patient in recovery position, YouTube has so many videos that can take you step by step on how to put this patient in recovery. Again, this is the position after a patient has convulsed, but not during an active convulsion.
Thank you so much, Dr. Doreen. I think when the patient is actively convulsing, the goal should be that to first stop the seizure.
Yes.
And then manage after. I know our time is so much spent, but we are going to have some questions and then discussion. I'm going to invite the online audience to ask some questions. However, before, there is a pertinent question that has been persistently reoccurring, came out as expectation, and has been coming out in questions about the vaccine. Dr. Wamala, can you talk about the vaccine and our Uganda current status about the vaccination, malaria vaccine?
What is the question about it?
So, in the expectation, people talked about malaria vaccination. Then in the question, someone is asking why children who are vaccinated are coming back again with malaria. Then some people want to know whether we have the vaccine or it's not there. When is it going to be rolled out? Yeah, many questions are coming about the same thing.
Thank you very much. So so far there are two malaria vaccines which have been approved by the WHO, and they have some technical notation which I will leave for you to find out. So one of them is R21, the other one is RTS stroke SAS01. So you can go back and read the nomenclature. But the essence of the vaccine is to prevent malaria, especially in children, because children and pregnant mothers are the most highly hit categories of people. So the vaccine is to prevent children from getting severe malaria and from actually dying because of severe malaria. So a number of countries in Africa have begun vaccinating, but for Uganda, the last time I heard, that is about in January, is that we haven't yet begun vaccinating, but we hope that before this year ends, we shall have begun. So somewhere around in September, October there, that's when we are hoping to start the vaccination. But for now, only children, not adults.
Okay. Thank you so much, Dr. Wamala. So we are going to go to our online audience. So please, guys, you can put up your
You can raise your hand in the chat and we'll click on you. 2 people are ready to go. I have Simon Bango, and then Benjamin. Simon, can you go first? Meanwhile, as we are asking questions, we have a post-test. So our online audience, you can be filling in, answering those questions and asking questions, and our experts are going to be answering the questions. So Simon, if you're there,
Hello.
can you please unmute?
Can you hear me?
Yes, we can hear you.
Okay, thank you so much for the presentation. But I had asked a question about clinical malaria. We are in the hospital and the words like clinical malaria. Can we understand of this? I mean, is there such a thing as a clinical of malaria without a positive BS?
Okay, Simon, you are not so much clear. Can you please come up again?
Hello, can you hear me?
Yes, we can.
You can hear me now?
Yes, we can hear you.
Yes, my question was about, I've heard of that term many times, and I wanted to know whether can we make a clinical diagnosis of malaria? Like, can we treat malaria without a positive BS? Can we say maybe this patient might have malaria, like without a positive BS? Is there such a thing as clinical malaria? I've heard of that word and I don't know what it means.
Oh, okay. Thank you so much, Simon. It has been noted. Malaria without end of the investigation being positive. Benjamin, can you please go ahead to ask your question before I pick other people?
Thank you so much. I'm Benjamin, Wamala Medical Hospital. I have around 3 short questions. One, I wanted to find out the instance of giving IV artesunate for 7 days. Like when you finish the 3 doses of 24 hours that you continue for all day, once a day for 7 days. Then if we give artesunate and BS still shows presence of parasites, and you maybe go to a second option, that is artemether, still showing a positive, and maybe this child or an adult person is having severe anemia. Do you switch to IV quinine? Then thirdly, we had some discussion, that's a CM, and the discussant was trying to say that artemether lumefantrine is contraindicated in pregnancy. I wanted more light on experts, because in the clinical guidelines of 2023, I read that AL or ACTs are recommended.
Okay,
Perspective of the trimester, but I was surprised that they get experts without me. Thank you.
Thank you so much, Simon. I'm not seeing any other more hand raised. I will allow our experts to first start for those ones, and maybe we get others.
So clinical malaria, that is a negative, either negative RDT or the BS is negative. So there are a number of reasons which can make the RDT or the BS to be negative, yet the patient actually has malaria. So some of them are like, include one, low peripheral parasite density. Could be a technical error by your lab personnel. Sometimes the parasites are not yet in the periphery, in the peripheral blood, and they are still sequestered in the organs, the spleen, the bone marrow. or sometimes patients come in when they have taken some antimalarials, partially taken some antimalarials for some days. So yes, the guidelines give a provision that yes, a patient may have a negative RRDT, a negative BS, but you need to scrutinize very well whether the signs and symptoms are in line with severe malaria. So if this patient has a headache, has a fever, acute signs and symptoms of severe malaria, and you cannot attribute this to any other diagnosis, then yes, the guidelines give you a go-ahead to treat this patient as having malaria. So yes, there is an allowance for treating a patient as malaria despite having negative what? RRDT or BS. The other question was the attachment for 7 days. It depends. If your patient, after the 3 doses, cannot tolerate oral medications yet, the guidance is you keep them on artesunate, on daily artesunate, till when they are able to tolerate oral medications. So some patients take long to tolerate. So you may reach 5 days when the patient is still vomiting, but you are still keeping them on injectable what? Artesunate. But those are really very rare scenarios. But normally, after 3 doses, patient is fairly stable enough. You begin the orals. But yes, artesunate, you can even reach 7 days. That is, if your patient is not able to take the oral, you keep them on the IV, which you give daily. The other question was what? So SCTs in pregnancy, yes, they are safe. They can be used. Actually, when you get a pregnant woman with severe malaria, please give them artesunate. Is safe, no matter the trimester. You give artesunate and follow them and follow it up with artemisinin combined therapy, as you do for other patients.
Thank you so much, Dr. Wamala. You've been elaborate. So, Henry, we have Henry Mukasa, and they have their hand up. They can proceed and.
There was a question I asked on quinine with severe anemia after all the artesunate or artemether still failing. It's not tackled.
So, can you ask the question? Since now you've been able to unmute.
I was asking, you've used artesunate, still the parasites are seen. Then now you switch to artemether, still the parasites are seen, and the patient is severe anemic. Do you switch to quinine?
That's what our experts guided us, that the first line treatment is the artesunate, then the second line is the artemether, then the third line is the quinine. So quinine is the third line.
And you shouldn't forget to treat the anemia, because it is likely to kill that patient faster than the parasites.
Okay. So I'm not seeing, okay. I'm giving one more chance to Modesta. Modesta Kitty.
Good afternoon, everyone. This is Dr. Modesta from Kalongo Hospital. I want to ask about the issue of gametocytes. Several times you've had cases where you treat the malaria, the patient improves, but the gametocytes seen in the slides. So these gametocytes, do you have to go ahead and treat it, or do we leave it? Because most times the patients have already improved, but we are seeing gametocytes. That's the question.
Okay, thank you so much, Dr. Modesta. Dr. Wamala, can you tackle that?
So Gametocytes are sexual forms. So here we are more concerned about the asexual forms of the parasite.
So our time is spent. This time I thank everybody who has joined onto the call. We are going to have closing remarks from our experts. And yes, our team that has been behind this is going also to give us the correction for the post-test. So I'm going to start from a person who is at the extreme left. Sister Lucy to give us your closing remarks, then Dr. Mara, and then Dr. Doreen.
Thanks once more, Madam Moderator. In fact, me, I'm so happy because I've also learned a lot right from here. And to our listeners out there, I think they've also got a lot from us today. So mine is just a word of appreciation. I have nothing much to say. Thank you for listening.
So thank you, moderator, and the ECHO fraternity for once again giving me an opportunity to come and sit in the hot seat. So the topic of today was malaria, a very hot topic, and actually there are so many questions. Some of them we have not had time to respond to, but all that shows that the topic is a topic of interest, public health importance, and it is still very relevant in our setting. So yes, we have shared a few things, but you need to go back and read more about this topic and learn more for the betterment of our patients. But once again, I thank you for the opportunity. Have a nice evening.
Yes, thank you, moderator. Thank you, SID Global, for this opportunity. I just want to close by saying that as clinicians, let's go back to basics. Let's go back to our clinical skills. Let's remember to look, to listen, to feel, use our hands, use our eyes, use our ears. Remember that as a clinician, you need to make a clinical judgment about the patient who is in front of you. Take a proper history of your patient and ensure that by the time you're done with your history, you have an idea of what is happening in your patient. But also remember that, ensure that you have proper monitoring done for your patients, ensure that you anticipate complications and give the right medication with the right justification. Thank you very much.
Thank you so much, Dr. Doreen. We have one of our online audience participants. Castro, you're not happy because we didn't pick you, but I thank you so much because you've written your comments. You're saying we should stick to the guideline. Let's test, treat for malaria. Where you're unable to perform the test, consider referring patients or samples. Clinical malaria has masked many diagnoses for patients. Thank you. Thank you so much. This point has been noted. I'm sorry for not picking you. Very many people have been putting up their hands, but our time is so much spent. So at this time, I'm going to allow the team that is behind this to tell us how the whole session worked and the correct answers. Then we will have our video on. Then we shall take pictures.
Thank you very much, moderator, for moderating such a wonderful session. I hope all the participants can see the poll results. For the first question, I see Maxwell chose the right answer, which was 7 to 30 days. question was saying, following an infectious mosquito bite, the symptoms of malaria didn't appear after an incubation period of, and the answer was 7 to 30 days. I also see, I will highlight the ones where maybe a lot of people didn't get it right. For this one, most of the people got it correct. It was cardiovascular collapse and shock. This will be features of severe malaria in form. So that especially have to be treated as severe malaria. And then for question 3, this is where we had a lot of contention. Asking which of the following is commonly associated with acute splenic rupture? And 40% chose Plasmodium falciparum, and 51% chose Vivax. And the answer was Vivax. Maybe Dr. Wamala can comment on that towards the end. And then question number 4 was quite clear. I think Dr. Wamala had highlighted it during the presentation, so there was no competition there. And then also the last question was quite clear. Dr. Wamala, would you like to talk about the question number 3? About malaria form that causes acute splenic
Yes, it is. So Vivax is more commonly associated with the causing acute splenic what? Because it has it is very much pro-inflammatory as compared to falciparum. By pro-inflammatory, I mean it excites the inflammation more than P. falciparum. So actually, P. vivax may have just a few parasites, but there's a lot of issues in the system. So yes, it causes a rupture of the spleen more common than P. falciparum. So patients who have what we call hypermalaria splenomegaly, usually their spleen don't rupture because they have been enlarging for quite a long time, so they have a very thick capsule. But this one, the splenomegaly is acute, and spleen the capsule can easily give way. So patient may come in with severe anemia, hypotensive, and an acute abdomen. Beware. Thank you.
Okay. Thank you very much, Dr. Wamala, for that clarity. So our next session will be on the 29th of March, to be a Friday at same time, and we'll be talking about meningitis in children and adults. And for this session, feel free to get all our materials on our different platforms. We have a website which we have already shared in the chat. If my team could help me share the link again. We also have a YouTube channel for all those who are unable to attend the session. We post it there. So feel free to go on there and watch the previous sessions. You can feel free. We also upload the presentations that we had today onto our website, and there was guidance on how to access those, which was also sent by the writing there. The link for the CPDs has also been uploaded. Please register for the CPDs. We'll be uploading them in a few days after we've gathered all those that we registered. Please remember, register using the link so to ensure that your registration number is captured. So besides that, I would like to ask the whole team to turn on their video videos so that we can take a few screenshots for memory of this session. I want to see your big smiles. Okay, we are still capturing. Please keep the videos on. Keep them on as we're taking a few. Glad to have you for today's session. I keep smiling.
I can see a team.
Where is that? Okay. Thank you all for logging in today, and we will be back in 2 weeks, exactly 2 weeks. We will be back and we'll be sharing the link in the meantime. For the other questions that we get answered, we will be, for all those on the National Echo group, we will turn them into PDF and get the answers and we'll be posting them there. So thank you all for attending today and have a nice weekend, everyone. Bye-bye.
Bye.
Nice to meet you. Bye.
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 Bye. Bye.
Bye.
Bye.